Hello there, my name is Natalie Tuttle and I'm one of the pharmacists here at UTMC, and I would like to talk to you about the management of acute agitation in the emergency department. My objectives for this presentation are to outline the possible causes of agitation delirium in the emergency department, assess when it is necessary to administer pharmacological agents for the treatment of agitation delirium, and determine an appropriate agent based on the underlying cause. So causes of agitation delirium could be due to medical conditions, intoxication withdrawal, mental health conditions, and other reasons. Medical conditions to consider: head trauma, encephalopathy, especially if we're considering from renal failure or hepatic failure. Some metabolic conditions to consider would be hyponatremia, hypocalcemia, and hypoglycemia. There's also hypoxia, seizures, acute delirium, and dementia behavior or psychological symptoms. So the important thing to consider is that we need to make sure that we are recognizing and treating the underlying cause, and rather than just assuming that it's psychiatric in nature. When we're talking about intoxication or withdrawal, we're talking about alcohol, hallucinogens, stimulants, cannabis, especially when we consider the legalization of marijuana. There's a lot of intoxication related to edibles because patients consume much more than they normally would because the onset is slower. There's also the possibility of synthetics, opioids, and benzodiazepines. Mental health conditions to consider: psychiatric disorders, mania, agitated depression, anxiety, borderline personality, and antisocial personality. Other things to consider: developmental disabilities, situational crisis, impulse control disorders, and pain in patients with intellectual disabilities. Again, this is important to make sure that we are recognizing the underlying cause, because if we have a patient that's in pain and acting out because of their pain and they don't have the ability to communicate, if we can treat their pain, we don't need to treat with an antipsychotic. Factors that we need to consider, regardless of the cause of the agitation: we need to make sure that we are maintaining safety, that we're maintaining safety for the patient, the staff, and others. We want to make sure there's enough people around to restrain if we need to. We need to be aware of the environment and make sure that we remove any potential items that could be used to harm the patient or other people. And we need to make sure that we are alerting security and mental health to triage if necessary, and make sure that we have someone available for one-to-one observation if it's necessary. So everyone in the emergency department should have some training on de-escalation. We want to make sure that we are approaching the patient in a calm, confident, non-threatening manner, that we're using short, clear sentences, and that we're not using medical jargon. The patient is in a very high agitation state, and so the patient probably doesn't have the capacity to understand completely, which is why we need to speak slowly and calmly with a steady voice, and make sure that we're not raising our voice. We want to make sure that we're empathetic and non-judgmental, and that we're actually listening to the patient's concerns. We want to introduce ourselves and our role, and also try and lead the discussion and engage the patient. We want to use clear, steady voice again, and not raise our voice. If the patient raises their voice, we want to make sure that we're pausing and letting them speak and vent if needed, which can be difficult when you have a patient getting agitated to keep yourself calm. But it's important to make sure that you are the rational voice in the situation and that you remain calm so that you can hopefully not need to go to medications. So we want to emphasize the desire to help and to listen to the patient's worries and their fears and their unmet needs. Again, we want to avoid provocative statements. We don't want to say, calm down, if you don't settle down, XX will happen. If we think about it, one of the surest ways to fire someone up is if we tell them to calm down, or if we threaten them with, you better stop or else this will happen. So we want to make sure that we are not escalating that behavior, and we want to make sure that we are not perceived as a threat to the patient. So while there may be other staff members there, really only one staff member should be engaging the patient. We should entrust relatives or staff to help if needed to de-escalate the situation. Some general recommendations to consider: the use of medication as a restraint, in order to restrict the patient's movement should be discouraged. So the Joint Commission actually requires the same level of scrutiny and medical evaluation and record keeping for medication as a restraint as they do for physical restraint. So we need to consider that if we are going that measure for medications as a restraint. Again, it's highly discouraged. Non-pharmacological approaches should be attempted first before medications are administered. When we are medicating patients, we want to do this to calm patients, not to induce sleep. If we take them to the point where they're snowed, we're not going to be able to help with their underlying medical condition. So we want to make sure that we're calming them down without putting them to sleep. Patients, whenever possible, should be involved in the process to choose what medication to use. So hopefully in this manner, we can help the patient decide whether we want an oral medication, intermuscular medication, etc. If the patient is able to cooperate and take oral medications, we want to make sure that we are doing that before we are giving anything parenterally. So what medications do we use? We have the first generation antipsychotics, droperidol and haloperidol. I have droperidol still listed here because you might hear about it still a lot. Droperidol has actually been removed from the market due to risk of QT prolongation, and this risk actually may be controversial. Although there is some data to support that there were some patients that had QT prolongation with droperidol, it may have been overblown. So there is the possibility with some push that this drug may come back. So haloperidol also has the risk of QT prolongation, especially with larger doses and especially if we're giving it IV. So if we do need to give haloperidol IV, we need to make sure that we are using ECG monitoring during the administration. Extrapyramidal symptoms, or EPS, such as dystonia or neuroleptic syndrome, may occur. If they do occur, we can give lorazepam, diphenhydramine, or promethazine, but we need to realize if we are treating the EPS that it's also going to increase the sedative risk of the haloperidol. If we give high doses of haloperidol, it can also cause catatonic reactions due to the central dopamine blockade. Second generation antipsychotics, as seen here, cannot be given IV per the FDA guidelines. There is some data to support olanzapine and ziprasidone as IV in the critical care population, but no data that I have seen for use in the emergency department, and the FDA only has it approved for IM and oral administration. Aripiprazole is highlighted in red here because although it does have a indication for agitation, it appears to be less effective. And it is no longer available in an IM formulation. It's only available in oral. It used to be available in the IM formulation for immediate release. Now it is only available in a long-acting. The oral second generation antipsychotics, we have risperidone and quetiapine. Quetiapine is in red because it has a high risk of orthostatic hypotension, especially in patients that are volume depleted. So again, not a good choice for the emergency department, but risperidone seems to have a good use. There is less risk of EPS with the second generation antipsychotics. Benzodiazepines can be used, and we're all very familiar with benzodiazepines. They can be over-sedating, and they have the potential for respiratory depression or hypotension. We need to especially consider this in patients that are already having underlying respiratory conditions, or if they are already on other CNS depressants such as alcohol, this risk for respiratory depression actually increases. Other medications that are sometimes used to help with agitation, we have diphenhydramine and hydroxyzine, and clonidine may also be used for alcohol withdrawal, and we will discuss that later. So this slide is just here for your reference. These are medications that are readily available in the AccuDose in the emergency department at UTMC. So as you can see, we have some haloperidol, some second generation antipsychotics, the benzos, and other medications available if needed that are readily available in the AccuDoses in the emergency department. Any other medications would be available at UTMC, they just would need to be sent up from the central pharmacy. If we have a patient who we expect their agitation is due to intoxication, most of the time we're going to choose a benzodiazepine to help calm the patient down. There are some patients that are chronic amphetamine users that will actually develop psychiatric and psychotic symptoms. So if we have psychotic symptoms, we want to treat with an antipsychotic, which should be added to the benzodiazepine. If we have a patient that's intoxicated from alcohol, which again, remember, is a CNS depressant, we want to, most of the time, just let the alcohol wear off on its own, and medication should be used very sparingly. Benzodiazepines, as we discussed before, should be avoided because of the increased risk of respiratory depression. If we need to treat, we should use haloperidol as our first choice, and olanzapine and risperidone could be an alternative agent. If we have a patient that is in an agitated state due to withdrawal, if it's due to an alcohol or a benzodiazepine is the drug of choice. When you have withdrawal from alcohol or benzos, you have rapid loss of GABA receptor inhibition, and it's implicated in producing delirium. Clonidine may be helpful in reducing the sympathetic overdrive of alcohol or benzodiazepine withdrawal, and it may ease the delirium and agitation associated with that withdrawal. For other agents, it's best to replace with an agent that has similar pharmacological properties. So if we have nicotine, we're going to replace with nicotine. If we have opioids, it's actually best to get an expert in detox for the management of the opioid withdrawal. So there's special management required for Suboxone or methadone to be used along with symptomatic relief. Often these patients that are opioid addicted also are much more complex and have multi-system abuse. If we have a patient that's coming through the emergency department, just to kind of shore up the rules for you as far as the Ohio State Board of Pharmacy and the federal regulations go, if we have a patient that comes in that's already being managed for their opioid withdrawal, and they're here for any other reason, so we're treating their medical condition, they have an MI, that sort of situation, we are legally allowed to give their Suboxone or their methadone at the doses that they require. If they come through the emergency department and the only reason that they're there is for their withdrawal, we can administer a dose if deemed that they did not receive their dose at their treatment center. We can give a one-time dose through the emergency room, and we can give it one dose at a time for a maximum of 3 days. If the patient's agitation is due to a psychiatric illness, makes sense if we have a psychiatric illness that we would use an antipsychotic. Generally, we would use a second generation over a first generation because there seems to be more data. If the patient will accept oral, we have risperidone, which is the safest. As I pointed out before, the risperidone is loaded in the Acudose of the emergency department, and the dosage form of the oral that is loaded in the Acudose is the oral dissolving. So it is a rapid onset oral dissolving tablet. If IM is needed, ziprasidone or olanzapine would be preferred. If the initial dose of the antipsychotic is insufficient, instead of giving a second dose of the antipsychotic, it's actually preferred to give a benzodiazepine, and usually lorazepam is used. If you have agitation associated with delirium, first we need to recognize the signs of delirium. So we have decreased level of awareness, disturbance in attention and cognition, and it can fluctuate over the course of hours. Visual hallucinations, visual perception disturbances. When we have these signs of delirium, it signals that there's an underlying medical disturbance affecting the brain function, or there's a rapid change in the established environment of the brain. So once delirium is identified, the cause needs to be identified as soon as possible and corrected. So as we've said before, whenever possible, we need to correct the cause of delirium. So if it's alcohol withdrawal, benzo withdrawal, sleep deprivation, we're going to treat as discussed before. We're going to give a benzodiazepine. We're going to induce sleep. If it's caused from something else, an antipsychotic may be needed, especially a second generation. If you use haloperidol, it should be used at low doses. So we're talking 2 milligrams, 3 milligrams. less than 5 milligrams. Benzodiazepines actually should be avoided because they can exacerbate the delirium. So what if we have a patient that we have no idea what is causing their agitation, or it's very complex and it's multiple reasons causing their agitation or delirium? So again, if there's psychosis present, we want to give an antipsychotic. If there's no psychosis and the etiology is unknown, a benzodiazepine would be our first line of treatment. It is possible if we give an antipsychotic that we could give the haloperidol, lorazepam, and diphenhydramine together, and you will often see that. But again, realize that we might want to use a little bit lower doses of the haloperidol and lorazepam so that we are not snowing our patients. We want to make sure that we're calming them without inducing the sleep. Listed here is just the algorithm based on the treatment protocol from the Western Journal of Emergency Medicine. It just outlines all that we've discussed. I will also supply my email address at the end of this presentation. You should have been supplied with a pocket card, but if you have not, you can email me and I will make sure to get you a copy of this to keep in your pocket. So conclusions. The pharmacological treatment should be based on the cause of agitation and should only be used if attempts at de-escalation were unsuccessful. Calming is the goal without inducing sleep. It's very hard to complete neurochecks on a patient if the patient is sound asleep. Oral should be used first if ever possible. If there is psychosis present, we want to make sure that we're using an antipsychotic. Second generation is preferred in most situations. Unless it is due to alcohol withdrawal, then haloperidol would be preferred, which may also need to be administered with a benzodiazepine to reduce the risk of EPS. So if you have any questions, you can send an email to me at natalie.tuttle@utoledo.edu. And also if you would like a copy of the presentation or the pocket card, if you did not already receive it, you can email me that as well. So I hope that you have learned something about the acute management of agitation in the emergency department, and thank you for your time.